Good morning. My name is Mike Fidali. I'm one of the nurses here with MedEvac. I'd like to welcome you all here to MedEvac. Hope your orientation is going well. What we're going to talk about today is to do a pharmacology review. And this presentation, my goal is to not bore you and just recite medications back to you. My goal is to go over some of those medications that we use a little bit more frequently or may encounter in the transport world, some of those transport considerations for those medications and how they relate to our protocols, and hopefully to group all of that together. So I'm hoping that this is going to be a relatively interesting presentation and to bring up some points that maybe you can discuss with your preceptor while you're out there on orientation and get a better idea of how you would utilize these medications when you're out in the field. All right, so the first thing we're going to talk about is STEMI versus NSTEMI, and your initial patient presentation that you're going to get is a 72-year-old that is here with 2 hours of substernal chest pain and epigastric discomfort. Radiates their left arm and their jaw, they're diaphoretic and nausea. And they come into the emergency room at this hospital, they do an initial 12-lead EKG which shows this. I'll give you a second to take a look at that. Hopefully, based off your reading from the EKG, you're able to see the ST elevation in the V leads, V1 through V6. We do have some reciprocal changes in leads 2, 3, AVF. And I'm hoping that at this point that you're able to classify this EKG as a STEMI. Based on our protocol, there's a couple things that we would like to do as far as treatment goes. So with that being said, what kind of medications would you be off the top of your head thinking about for your chest pain, acute MI, STEMI patients? And the first thing that comes to my mind would be these particular medications over here based off of our protocol. So per the network, what our cardiologists would like us to do in these particular situations, we want to make sure that we have oxygen in our patients, not necessarily doing the high flow, but we just want to keep that oxygen saturation greater than 94%. So nasal cannula is fine in these particular situations. Aspirin, we want to get 324 on board if they don't have any contraindications to the aspirin. Our nitroglycerin, we can either do sublingual or we can do an inch of paste. Sublinguals would be usual tablets, inch of paste on the chest if they're not able to tolerate those sublingual tablets. Or if we are doing an interfacility transport, the other option is that they may already be on a nitroglycerin drip. With the nitroglycerin drip, we want to make sure that we're titrating that appropriately based off of their blood pressure. Same parameters that we would be looking at when we're doing the sublinguals or the paste. However, we have a lot better control with controlling their blood pressure and their pain with the IV infusion. So that IV infusion is going to be starting usually around 5 to 10 mics a minute, and we're going to increase that by 10 mics a minute to a max dose of 300. The caveat to that is that if we know this patient is going to the cath lab, with which an EKG that looks like this, I would imagine that patient is going directly to the cath lab. The caveat is that if we have less than 100 mics a minute on that nitroglycerin drip, you want to go ahead and discontinue that, as well as if there's any heparin infusing, you want to discontinue the heparin drip. That's cath lab patients only. It's a lot more of a hassle for them once they get into the cath lab to manage that from there. They have other tricks up their sleeve, and as soon as they can reperfuse that artery, there really isn't or shouldn't be a need for that nitroglycerin drip for very much longer. Next would be our Plavix. Plavix, we want to make sure that we're loading our patients up with a loading dose of 600 milligrams or equivalent to that 600 milligrams. So if we're talking about that we picked this patient up from the scene or from an emergency room at 9 o'clock in the morning, and at 7 o'clock in the morning they took their daily dose of 75 milligrams of Plavix, we are going to give them up to a total of 600 milligrams for that particular day. If they haven't been given their Plavix and they're coming from a referring facility, make sure that you're discussing with the emergency room physician there as to why they haven't received that Plavix, just to make sure that there's not some kind of contraindication or something that they're not missing that we need to make sure that we pick up. Next, we have our heparin infusion, or excuse me, our heparin bolus. If they do have an infusion and they're going to the cath lab, like I said before, we want to discontinue that heparin infusion. However, we do want to make sure that we're properly anticoagulating these patients. So heparin is going to be a 4,000 unit bolus, which in our 5,000 unit vials, it should be about 0.8 mLs that you're going to go ahead and infuse. Just make sure they don't have any contraindications to that heparin. Those contraindications may be if they're currently taking Coumadin, Pradaxa, Xarelto, Eliquis, any of those, they would already be anticoagulated, and we would end up going a little bit overboard on the amount of medication that would be in their system. Additionally, double check to make sure that they don't have any history of gastrointestinal bleeding, subarachnoid hemorrhage, or any other known bleeding disorders that would contraindicate them to the heparin. And if we do have a patient that happens to be tachycardic and or hypertensive and enough pressure to work with, we can consider doing low pressor for those patients. That would be an IV dose of 5 milligrams times 3. It is a beta blocker, so you're going to have the effect on both the heart rate and your blood pressure. So make sure that you have at least 70 on your heart rate to work with, and you want to make sure that if their blood pressure is that high that we're not drastically bringing them down, we want to slowly bring that blood pressure down to within normal limits. Any questions on those medications so far? Hopefully not. I'm hoping that whoever would be there to give you guys this lecture will be able to answer any of those questions for you. But what I do want to pose a situation to you is that if you see this EKG and you have those elevations in V1 through V6, and you have an adequate blood pressure and you're not having any considerations with inferior wall involvement, then you can go ahead with all these medications. But my question to you is, how does that change if you see an EKG such as this? So I'll give you a second to review over this EKG and see if you would make any changes to your treatment. I'm hoping that by now you're able to see that this patient does have an inferior wall MI with the ST elevations in leads 2, 3, AVF, and some reciprocal changes in 1 and AVL. So based on this 12 lead, as far as our care goes, the first and foremost thing that you want to do is be very cautious with some of the medications that you're giving. These patients have a very high propensity of becoming bradycardic and hypotensive. So we need to make sure that we don't have any actual right-sided involvement. So the way to do that is to do your V4R or do a right-sided EKG. If your right-sided EKG is positive, we want to refrain from doing any nitrates in these patients because they will almost guaranteed go hypotensive and bradycardic, get very diaphoretic, nauseous, start vomiting on you, and nobody likes that in the back of an aircraft. So with that being said, if you do not have a positive V4R, you can continue with nitrates, but be very cautious with those. Again, based off your patient presentation, they often will get very bradycardic and very hypotensive, and that's one of the things we want to try to avoid. So aside of that listing of medications that we just discussed before, you want to stay away from those nitrates, and you want to also have a 250 bag of fluid ready to go just in case you need to bolus those patients. The last thing I'd like to talk about with regards to our acute MIs is going to be morphine versus fentanyl. I don't have that up on here, but morphine is going to be that decreasing preload and afterload. It's great for those patients that are having an MI, but again, in that EKG that I'm showing you on the left-hand side of your screen, where you have the inferior wall MI, your morphine is probably going to become cause that person to become hypotensive as well. So I'd be very cautious with that. And you may end up having some more bradycardia issues. So it's not to say to not do it, but just be very cautious with those particular medications. And that's why fentanyl may be a great alternative for you with those medications or with those symptoms, because of the fact that they're not going to have as much effect on blood pressure nor on your heart rate. So you can more safely administer your fentanyl to those patients that are having those inferior wall MIs, especially if it's going to help control their pain in the meantime. All right, so let's take a look at another patient situation looking at your STEMI versus your NSTEMI. Your initial patient presentation is going to be a 68-year-old that's complaining of left-sided chest pain and left arm numbness for 4 hours. The treatment, they were treated for acute coronary syndrome while they were in the emergency room, and they did have some decreased pain with nitroglycerin. They were able to do some lab results, and the remarkable lab is that they have a troponin of 1.74. Taking a look at their EKG, based off the referring facility, this is what you see. I'll give you a second there. So looking at that EKG, they may have started a little bit of a left bundle branch block, which may obscure our view if they are having something underlying as far as an MI goes. The other thing to make of note there in your EKG and your V leads, especially V4 through V6, you do see some ST segment inversion or T-wave ST segment depression there. So maybe some signs of some ischemia rather than infarction. So this person definitely has some strain going on with their particular heart, and we need to treat them a little bit differently as such. So they're not going to get classified in the STEMI category, this would be your N-STEMI patient. So our medications change a little bit with these particular situations. First and foremost, this is only in regards to an interfacility transport. We can't be diagnosing N-STEMIs out in the field and giving all the usual medications that we give. So this is going to be done by an advanced practitioner at a referring facility. So they're going to need to look at not only the EKG, but also their labs and the patient situation, maybe refer to a prior EKG to see if there's any changes that have occurred. So those are things that we can't really do when we're out in the field, so that's why this is related to interfacilities only. The first question I need you to ask yourself and to ask the referring facility when you get there and you have a patient that's presenting as an N-STEMI is how long ago was that last EKG performed? If you're looking at this EKG and it's been greater than 10 minutes, or you have somebody that's classified as an N-STEMI and it's been greater than 10 minutes since that previous 12 lead, we need to take on the responsibility ourselves to do a repeat 12 lead EKG to make sure that they haven't crossed over from that N-STEMI into the STEMI stage. So as long as there's still an N-STEMI, EKG hasn't changed, you're not seeing any overt ST segment elevation, then we should be good to go. Remember, in order for it to be classified as a STEMI, you need to have greater than 1 millimeter elevation in 2 contiguous leads. Unless you're talking about leads V3 and V4, then you need greater than 2 millimeters of elevation in those particular leads with your associated symptoms. So if this EKG is within the 10-minute time frame, then we can go ahead and start treating them. Hopefully that's been done at the referring facility, but those medications that we'd like to go ahead and give them are going to be pretty similar. Your oxygen is going to be the same as far as keeping their O2 sats greater than 94%. Aspirin is going to be 324 milligrams, just like we did before. The nitroglycerin, try to stick to the sublinguals on these particular patients unless that therapy has already been initiated by the referring facility and they already have them on a pretty significant nitroglycerin drip or whatnot, or they already have paste on them. But if we are the one that's going to be continuing therapy, try to stick with the sublingual route and see if you can get adequate pain control with that medication. Plavix, this is where your dosing changes. Instead of loading them with the 600 milligrams, we're going to only do 300 milligrams for those N-STEMI patients. They're probably going to the cath lab at some point, but they need to do more investigation before they take them there. So we're only going to load them with 300 milligrams. And lastly, take a look at their heart rate if they are greater than that 120 or you have that blood pressure that is elevated. You can look at doing 25 milligrams of low pressure, or you can try doing the IV dosing if you feel that their condition warrants that. Again, that's something you certainly can have a conversation with the cardiologist if you feel so needs to be done, but I wouldn't delay transport in those particular situations just to get that medication on board. We don't carry the PO version of low pressure, so we only have the IV doses, so if that's something that's easier for you and you can consult medical command and route, that may be a better option to do. So to move forward a little bit with some more of our cardiac medications, the next one I'd like to talk about is going to be Cardizem or your diltiazem. This medication is going to be specifically for your rapid atrial fibrillation patients, so take a look at that 12 lead again, especially if they do have a widened QRS, make sure that it's not a rapid AFib with an aberrancy, that we're not treating incorrectly and that this may be the more appropriate medication. Also, this is a calcium channel blocker, so you are going to get both a decreased heart rate as well as a decreased blood pressure with this medication. So be very cautious when you do that. Based off of our pre-hospital protocols, you're going to look at doing a 0.25 milligram per kilogram IV bolus, which may be repeated in 15 minutes at 0.35 milligrams per kilogram. What I can tell you is that if you're picking up patients from an interfacility or on an interfacility transport, these referring facilities may have already initiated that, but they typically don't go by this dosage. They may start them at 5 to 10 milligram IV bolus, followed up by usually a 5 or 10 milligrams an hour, and adjust from there as far as getting the appropriate heart rate and blood pressure control. So don't be surprised by those dosages, but what I do want you guys to be monitoring is to make sure that they're not getting bradycardic, hypotensive. They also can get a headache with it, maybe feel some dizziness. It can actually induce some congestive heart failure or a heart block because of how much we're slowing things down. So in those particular cases, you want to slow down on that medication or decrease that titration or potentially turn it off depending on what's going to occur. Lastly, I have seen many people actually convert on Cardizem. So once we've started them on the Cardizem, you'll start to see some P waves appear within their EKG once they start to slow down, and all of a sudden they'll switch on you and they'll convert to normal sinus rhythm. In those cases, I want you to do a repeat 12-lead EKG. Make sure that they're not actually having a STEMI, especially if they're having chest pain associated with these symptoms, and convey that to medical command if need be, and you would switch over to a different protocol. So once they do convert, though, they do have a very high tendency to become bradycardic because of the calcium channel blocker that's infusing, so you may need to decrease that titration once they convert for you. We do carry the Cardizem as an Advantage bag, so you're going to have a little vial that screws into the top of your 100 ml Advantage bag, and when you pop the cap on that and mix it up, will have your concentration will be 100 in 100. Next, I'd like to discuss Lasix. This is hopefully a review for many of you guys, so we don't need to spend too much time on it. But based on our protocol, you're going to be giving this during for your congestive heart failure patients. It is a loop diuretic, so it's going to work in the loop of Henle in your kidneys, help to speed the process up, and get rid of some of that excess fluid that's in their system. It does block the reuptake of sodium and calcium, so it's going to cause that increased urination. The downside is that you're also wasting those electrolytes with it. So when you have somebody that's been on this medication long term, they may be electrolyte deficient in some of those regards. Our standard is that we're going to give 40 milligrams IV push. Unless their daily dose is higher than 40 milligrams, then we're going to go ahead and give their daily dose IV. I do want to caution you that giving this medication too fast can cause some hypotension. We again talked about the electrolyte abnormalities, and again the side effect of giving it too fast is oftentimes ototoxicity, where they'll start having ringing in their ears. All right, let's move on to some hypertensive agents. We have a pretty extensive hypertension protocol that hopefully you guys are familiar with at this point, but I'd like to review over some of those medications right now. The two medications that are our go-to would be Cardine and Labetalol. So starting off with the Cardine again is a calcium channel blocker and antihypertensive agent. The pre-filled concentration that we carry is 20 milligrams and 200 mLs. And the dose that we would initiate that would be at 5 milligrams per hour or 50 mLs per hour on the pump. What they'd like us to do is to titrate that by 2.5 milligrams an hour every 5 minutes to a max dose of 15. And that 2.5 can go either way, so up or down depending on your patient's blood pressure and what parameters we want to keep them within. Contraindications or cautions to using Cardine would be someone with aortic stenosis, hepatic renal impairment, and heart failure patients. The nice part about Cardine is that we can titrate and get relatively precise blood pressure control with the medication. Next medication would be Labetalol. Looking at Labetalol, the OLOL indicates that it's a beta blocker. We carry the 100 milligram vials, and there's 20 mLs in that vial. So our dosage is typically 10 to 20 milligrams, slow IV push. Again, it's a beta blocker, so you go too fast, you're going to get hypotensive, you're going to get bradycardia to go with it. Your max dose for administration would be 300 milligrams. If you happen to have an infusion from a referring facility, those infusions, our standard concentration is typically 200 milligrams and 200 mLs. And you would initiate that infusion at 2 milligrams a minute and increase from there as needed to your appropriate blood pressure control. But as far as the aircraft or the ground side goes, we only have the 100 milligram vial for the IV push administration. Contraindications to your Labetalol would be second or third degree heart blocks or any obstructive airway disease. So as far as our blood pressure parameters go, let's talk a little bit about that and how it relates to that protocol. So like I said, hopefully you've had an opportunity to take a look over the protocol by now. But for those CNS hemorrhage or cerebral edema patients, our goal systolic blood pressure is going to be to reduce them to 140 to 160. Remember, we still want to perfuse that brain, and we want to still perfuse everywhere that we can within the body, but we need to make sure that pressure is not too high that they're going to blow a gasket even further. So we want to decrease them to around 140 to 160 systolically, and that should hopefully find a happy medium of maintaining perfusion while not being too high and continuing with bleeding. For those aortic dissection patients, we want to really bring that blood pressure as well as their heart rate down. So we want to bring their blood pressure down to 100 to 120 systolically, as well as their heart rate down to between 60 and 80. We want to decrease that workload and decrease that overall blood pressure, because if we have things too high, then you're going to end up blowing that dissection out even further, which is already going to be a nightmare to deal with. Same thing with those AAA patients. We want to make sure their blood pressure is within range. Those patients that are having a hypertensive emergency, so say you get to the scene and you have that patient that is 230, 235 over maybe 130 or so. We really need to get their blood pressure under control, especially if they're symptomatic with that. So you have your two options here to help control that blood pressure, but the goal in those particular situations, as long as they're not expressing symptoms of it being a CNS hemorrhage with their increased intracranial pressures, or no known history of aortic dissection or whatnot, we only want to decrease their blood pressure by about 25% of what they started at. And that should be over the course of about a day. So we don't want to drastically reduce these patients. We want to start to bring them down slowly, because what happens if you bring them down too fast is all of a sudden those vessels that have been held open for so long all of a sudden collapse on themselves. And when those vessels collapse, and you can get additional CNS symptoms that go along with it. So be very careful as to how quickly you're bringing that blood pressure down, and be careful not to titrate too quickly. And lastly, I wanted to just discuss ischemic stroke, because that's kind of its own little animal. We have another protocol for your ischemic stroke. But if you do have a patient that is having a known ischemic stroke and their systolic blood pressure is greater than 220, or their diastolic blood pressure is greater than 120, and they do not have any concomitant medical conditions, we want to permit that hypertension. And the reason for that is that we want to there's an area that surrounds that infarction called the penumbra, and the penumbra needs to still be perfused, and it oftentimes needs higher blood pressures in order to perfuse that penumbra. So keep those, or allow those patients to lie flat, allow them to have that higher blood pressure, and they'll be able to deal with that once they get to the comprehensive stroke center. However, if you have a patient that has that systolic blood pressure that's greater than 220, or a diastolic that's greater than 120, and they do have concomitant medical conditions, then those patients, we need to control their blood pressure. As well as if you have patients that is experiencing signs and symptoms or showing signs and symptoms of increased ICP, and their blood pressure is greater than 180 systolically, those are additional patients that we should try to control their blood pressure to get their symptoms under control. So I put this slide up here to just discuss the differences between the Cardizem and labetalol, and to bring in the transport considerations for those two medications. So I'm hoping that you had an opportunity to look through our IHOP drug bag right now to know that we have the 100 milligram vials of the labetalol, and then we have the 20 milligrams per 200 ml bags of Cardizem. And the reason I bring this up is some of the things I want you to be thinking about as to when you're going to utilize either medication would be, is this a scene call versus an interfacility? If we're on a scene call, we're usually moving as fast as we can to get this patient to a definitive care center. With that being said, it's probably a lot easier to draw up and administer IV boluses of your labetalol as opposed to drawing up your Cardizem into a syringe, putting it on the syringe pump, programming the syringe pump for a particular rate, and by that time you're probably at the hospital and not getting the appropriate blood pressure control anyway. So those are some things to take into consideration on your scenes versus your interfacilities. Sometimes on your interfacility you have a little bit more time, or you already have your pumps there that you can go ahead and get this initiated while you guys are still at the bedside. You also need to take into consideration the level of blood pressure control that is required or that you want for your particular patient. Once you give your labetalol, it's in, it's done. You can't take it back, you can't titrate it down. So once you've given that IV dose of labetalol, you're pretty much stuck with whatever results you get. Whereas if you have your Cardizem infusion, you can adjust that up or down. It has a relatively long half-life for the Cardizem. However, it is still a very titratable medication in that you will get immediate responses one way or another. So if you really need precise blood pressure control, you're really shooting for a specific range on those patients, your Cardizem may be the better choice in those particular situations. The other thing to take into consideration is it both blood pressure and heart rate control that you're trying to provide, or is it just the blood pressure control? Your labetalol is going to have a great deal of effect on your heart rate. However, your Cardizem may not have as much of a heart rate effect as going with your beta blocker. So that may factor into your decision as to which medication you'll be administering. And then also taking a look at how long you are from the hospital. If your patient becomes hypertensive during your transport, do you have time to set that Cardizem up, or is it an easier or more feasible feat to initiate your labetalol IV bolus? All right, so let's move forward with vasopressors. I'm going to talk about a couple different medications here. First one is going to be dopamine, which should be familiar to everyone. Dopamine is going to be an inotropic agent. Our standard concentration that we carry would be the 400 milligrams in 250 mLs. Our usual dosage is going to be starting around 3 to 5 mics per kilo per minute, and we want to titrate that by 5 mics per kilo per minute every 5 minutes to a max dose of 20. Contraindications or cautions with this would be with your tachyarrhythmias or if they have recent MAOI ingestions. The sometimes good part, sometimes bad part about dopamine is that it also has chronotropic and dronotropic qualities to it, so you're going to have an increase in that heart rate as well as the conduction. So I do caution you with those tachyarrhythmias. However, if you have someone that is bradycardic, it is a fantastic medication to help with both the bradycardia and their blood pressure. And per your ACLS guidelines now, the current recommendation is that both dopamine and or epinephrine are viable alternatives to pacing, so you can utilize that for your symptomatic bradycardias. Next would be your Levophed or your norepi. Used to be a thing of the past, but it's now making a comeback, especially when you talk about your sepsis patients. It is a very potent vasopressor, sympathomimetic. Our concentrations standard for the hospital would be 4 milligrams in 250, and we want to initiate that at 4 to 12 mics a minute. You're able to titrate that Q5 minutes up to a max dose of 30 mics a minute. Preferably, we'd like you to protect the drug from light so it doesn't lose any of its potency. And your contraindications or cautions with that would again be the recent MAOIs, or if you have an infusion site extravasation, you want to tend to that pretty quickly. The saying with Levophed was, Levophed, leave them dead, because of how potent of a vasoconstrictor, and those people that are on your Levophed long term have a lot of peripheral vascular issues. So, but in the short term, it is a fantastic medication for especially those sepsis patients when you have that massive distributive shock. And the other thing with regards to Levophed is that it is now part of our therapeutic hypothermia protocol. So once you've received medical command to initiate hypothermia therapy on your post-resuscitation patients and you need blood pressure control, Levophed would be your medication of choice. A couple more vasopressors. We'll take a look at neosynephrine or phenylephrine. While it's not a medication that is part of our repertoire or in our IHOP drug bag, it is a medication that I wanted to add in here because we are starting to see a lot more of this on our interfacility transports. So this medication, it is a synthetic sympathomimetic, causing that postsynaptic alpha receptor agonist. And basically that just means it's going to be massive vasoconstriction. Standard concentration for the hospital would be 50 milligrams per 250 mL, so if a facility is mixing it up for you, that would be what you can request. You want to initiate this medication at 100 to 180 mics a minute. I know that's a wide range. Typically what I will do is start around 100 to 120 or so, titrate up until I get adequate pressures, and then you want to start titrating back down again. And your usual maintenance dose is going to be somewhere between 40 and 60 mics a minute. So once you can get their blood pressure under control, you want to start trying to bring that back down as best as you can and figure out why they're hypotensive in the first place and start to treat that. Your contraindications to it would be hypersensitivities, hypertension obviously, or a VTAC patient. And lastly here for vasopressors would be your epinephrine or adrenaline. It is, again, a sympathomimetic catecholamine, has both alpha and beta adrenergic receptor actions, which again is going to cause massive vasoconstriction. Our concentration for our epinephrine standard for the network would be 4 milligrams and 250 of D5W. We want to initiate that at 1 mic a minute with a max dose of 10 mics a minute. Again, working towards that goal blood pressure and heart rate, your epinephrine is going to affect both the blood pressure and the heart rate significantly, so be very cautious with your titrations. Okay, let's talk about RSI and some of the induction agents that we utilize. So first and foremost, here's going to be your first-line induction agents. Well, most of us are going to gravitate towards the etomidate. Our dosage on the etomidate is 0.3 milligrams per kilogram. It's going to give you some very deep sedation, not necessarily going to knock out the respiratory drive, but it's going to give them some very deep sedation. We do also talk about etomidate in our protocols with reference to fracture relocations or doing some moderate sedation potentially for cardioversion or something along those lines. And that would be a half dose for that etomidate, but when we're talking about RSI, we want 0.3 milligrams per kilogram. There's still some talk out there about using this cautiously with your adrenal insufficiency patients. However, there's a pretty wide consensus that a one-time dose of that etomidate during those situations is okay to be administering. It's just though you don't want to do repeated doses or having continued doses of etomidate in those particular patients. Next would be your Versed at 0.1 milligrams per kilogram. I get a little bit nervous seeing that dosage, someone such as myself who's a 100 kilogram patient, and I would be getting 10 milligrams of Versed. I've never given 10 milligrams of Versed at one point, just because of the hypotension that's going to be associated with that. So it certainly is a wonderful medication as far as sedation goes, and not remembering a thing, but I will caution you with using Versed for your induction because of the hypotension. Ketamine, or Ketalar, is a relatively new medication to our repertoire of drugs. 2 milligrams per kilogram IV or 4 milligrams per kilogram if you're doing an IM induction. The nice part about ketamine is that it does have bronchodilator effects to it. So if you do have those asthma patients or those patients that you anticipate being difficult to ventilate and you need some bronchodilation to go along with it, ketamine is probably a better option over your etomidate for your sedation aspect of the RSI because of that. Additionally, it also has sedation and pain factors to it, so it'll be a less painful procedure for the intubation. But the downside to using your ketamine over your etomidate is that your ketamine is going to be a much longer acting medication, so if you do have any difficulties controlling that airway, it's going to be for a much longer time that you're going to have to bag them afterwards or assist them with their respirations. But your ketamine is less of a propensity to knock out the respiratory drive. And lastly on this slide is going to be your atropine. So that's going to be for your patients that are less than 1 year old. We want to administer 0.2 milligrams per kilogram during our ISI to prevent any kind of bradycardias that are going with it. Remember, when we go through the intubation process itself, we often stimulate things that may cause bradycardia or hypertension. So hopefully that atropine will negate that. Your minimum dose on your atropine would be 0.1 milligrams. All right, moving on to your paralyzing agents. I want to talk about 3 in particular. First is going to be your succinylcholine. Our dosage on that is 1.5 milligrams per kilogram. You're going to administer that after, or any of these after you have a sedation medication on board for that RSI. Your succinylcholine is going to be a defasciculating agent, so you're going to notice after you administer that succinylcholine, give it 30 seconds or so. Don't feel like you need to immediately go in with that laryngoscope and intubate. Give it a couple seconds, provide them supplemental O2, make sure that they're tolerating medication okay, and you will notice things start, their muscles start to twitch, start to fasciculate a little bit, and then all of a sudden you will notice a massive relaxation. And once you get that massive relaxation, that jaw should be nice and loose, you should be able to intubate without any issues at that point. Okay. Sux is a wonderful medication for RSI because of how short of a half-life it has and how quickly they recover from this. They're only going to be out for 2 or 3 minutes with regards to the duration of your succinylcholine, so you have enough time to do an RSI, but if you have any complications and you cannot get them intubated, they should recover relatively quickly with their own respiratory drive. But there are some significant contraindications to using succinylcholine. So I wanted to just discuss those a little bit quickly. First and foremost is hyperkalemia. Whether it's known or suspected, utilizing succinylcholine will facilitate higher potassium levels. So if you have someone that has a known hyperkalemia, such as your chronic renal patients who maybe missed their dialysis yesterday, that might be a patient that you want to steer clear of your succinylcholine administration on. If they do have severe crush or traumatic injuries, spinal cord injuries that would be greater than 2 days old, any burn injuries that are greater than 8 hours old, again because of the potassium issues. If someone would have a pseudocholinesterase deficiency, again, we're not going to always know that, but the problem with administering succinylcholine to those particular patients is that they will have extended paralyzation, sometimes lasting up to hours afterwards, and the body's unable to recuperate from that. So again, we don't want to be knocking out the respiratory drive that long. If they have a known history of malignant hyperthermia, and again, your malignant hyperthermia is going to be caused from that accelerated metabolism of those skeletal muscles. So signs and symptoms of that may be muscle rigidity, a rapid heart rate, and a very high body temp. We don't carry the reversal agent for it, which is dantrolene, but keep an eye out for those particular symptoms associated with your patients after administration of succinylcholine, because if you see that, you need to notify the receiving facility to have dantrolene ready to go for you. That's going to be the one thing that's really going to help negate that malignant hyperthermia. And also, if you have any neuromuscular disorders such as a muscular dystrophy, those patients are often not able to respond well to the succinylcholine, as well as penetrating eye injuries are also a contraindication for your succinylcholine administration. So it is nice because it has a short onset and a short duration, so we can recover patients pretty quickly from it, but we do need to be aware of those issues that could be contraindications with regards to the administration. I'd also like to discuss rocuronium with you guys, or Zemuron, our induction dosage. This is going to be our alternative to succinylcholine, and our RSI dosage of your rocuronium would be 1 milligram per kilogram. Again, it does a nice job of paralyzing your patients, but the problem is that this is a much longer acting medication, so you're going to be taking out the respiratory drive for a much longer period of time. What I seem to have noticed is that during the induction phase of an RSI, your rocuronium dose of 1 milligram per kilogram typically will keep them out for maybe about 10-15 minutes. Your repeated doses of that medication will often have a much longer period of paralyzation, so you may be looking at 30 to 60 minutes on your repeated doses, which again, your maintenance is at still 1 milligram per kilogram. But that initial dose will give you enough time. Again, a lot longer than your succinylcholine, so when you anticipate or if you run into any issues, you're going to need to support them the best that you can for a lot longer. Both your rocuronium and your vecuronium are not defasciculating medication, so you won't notice those twitching or the defasciculations going on within those muscles. I would also say with the rocuronium, give it just a little bit longer as far as the induction side of things. So your succinylcholine, you may see those defasciculations occurring maybe around 30 or 60 seconds after the administration. Your rocuronium, give it a little bit longer and you'll notice your patient just kind of relax altogether. And once that occurs, that's when you can go ahead with the rest of the RSI. As far as maintenance goes, we talked about the rocuronium still at 1 milligram per kilogram, but as far as your sedation and pain medications go, I just want to go through some dosages on those quickly. Your Versed is going to be your 0.05 milligrams per kilogram. As an alternative to that, you're welcome to utilize Ativan at 0.1 milligrams per kilogram, but a max dose on that of 2 milligrams at a time. Ketamine is also another option to continue to keep somebody down. Again, that ketamine does have some pain properties to it, bronchodilator factors to it, and the sedation. And that's going to be at 2 milligrams per kilogram IV. Our morphine is 0.1 milligrams per kilogram and fentanyl at 1 mic per kilo. Again, between the two of those, we tend to gravitate more towards the fentanyl side of things, just for the simple fact that it doesn't have as much of the nausea, vomiting to go along with it, neither the hypotension associated symptoms. So you are welcome to do either if you have enough blood pressure or they're allergic to one or the other, but we tend to gravitate to the fentanyl a little bit more. For your fentanyl, max dose of 100 mics per dose. You can repeat that if need be, depending on the injuries that are going on, but a max dose of 100 at a time. Lastly, for medications that I'd like to discuss would be Propofol. We don't have a specific protocol for Propofol right now, but we do have a protocol that will be coming down the pike here shortly. So a lot of times facilities that we go and pick patients up at that are already intubated have Propofol infusions. So I want you guys to be aware of the medication itself and how to appropriately utilize it. It is a very short-acting hypnotic. The concentration is typically 1,000 milligrams per 100 mLs. And if we're the ones that are initiating this, you're going to initiate it typically at 5 mics per kilo per minute, and to titrate that by 5 to 10 mics per kilo per minute, Q 5 to 10 minutes to your goal sedation. I'll talk about that here in about a minute. Your usual maintenance dose is going to be somewhere between 5 and 50 mics per kilo per minute. And depending on the source that you look at, the max dose is right around 80 mics per kilo per minute. The big thing to keep in mind with regards to your Propofol is that it has a very high tendency of making patients hypotensive, especially when they get boluses of the Propofol. So I would recommend having some IV fluids ready to go just in case, or be prepared to either decrease or discontinue your Propofol and utilize other means to keep that patient's airway secured and them adequately sedated and pain medication. So the other thing to note is that Propofol does not have any pain control associated with it. So remember, intubation itself is grounds enough for some pain control. It's a very painful process. So even if you do have Propofol infusing and they appear comfortable, you may want to consider doing some additional pain control on top of that. Contraindications to the medication would be if they have any egg, soy, or peanut allergies or a known hypersensitivity to Propofol. So it is a wonderful drug, especially in the transport world. It does seem to do a good job of controlling our patients. The only downside is when you start stimulating them with vibrations, such as being in an aircraft or hitting all the bumps in the roadway, they oftentimes need higher doses of that Propofol. So that's why I say be very cautious when you are titrating that up, that you don't cause them to be hypotensive. What I'd like you to keep in mind with regards to our goal sedation, if you can, try to ascertain and get a goal sedation either from the sending or referring physician to facilitate that or have a goal to work towards. When you look at EMS charts has the Ramsey Sedation Assessment Scale that you are able to document the level of sedation of your patient. And then there's also the Richmond Agitation and Sedation Scale, which is the scale that's on the bottom of your screen here. And both of those are adequate scales to utilize to judge how deep of a sedation your patient is in. They really like these, especially on your neuro patients, to be able to turn that Propofol off and in a couple minutes be able to give them an assessment. So these scales help them assess where the patient's at and where they need to be in order to do those particular assessments. All right. So now it's going to come a little bit more of the interactive portion of the presentation. What I'd like to do is to kind of do just a brief review of some drug math. I know it's horrible, and please don't think that I'm not thinking that you guys can do drug math on your own. If you are perfect at it and you can do this 100% of the time without any difficulty and you have a good method, then turn your ears off and stop listening at this point. But what I'd like to do is to run through just a couple calculations, show you how I personally do drug math in two different ways, and hopefully it makes your life a little bit easier. If you have any questions, certainly any of your preceptors should be able to help you out and figure out an easier way for you to do that math in those critical situations. So first and foremost, I want to just talk about the two different methods that I'd like to show you, and then we'll kind of plan it out on the screen here and see how all of that goes. First and foremost is going to be your factor method. And with the factor method, you're going to be looking at the concentration of your medication and what concentration you would like to be, or what units you're going to be administering this medication in. So if you have a medication that is produced, or the concentration of that bag is in milligrams per milliliter, and you're going to be administering that medication in mics per kilo per minute, we need to do a type of breakdown of that to get it to the appropriate units and then relate that to your patient's weight and dosage. So the first thing you want to do is look at the milligrams that are in the bag and divide that by the mLs that are in the bag. Times that by 1,000, which at that point will give you your micrograms per milliliter. You want to divide that by 60, and then also divide that by your patient's kilograms. And what that will give you is your total factor number. So the nice part about that factor number is constant for that medication for that patient. So the only thing you need to do then, as far as once you've figured out that particular factor number, is to use your desire over have method, and that will give you your medication rate. Okay, and this will make more sense again in a minute. The other option is that if you're looking at, if you're running a medication that is not weight-based, so it's not mics per kilo per minute, it's just a mics per minute based calculation, and you do not have to factor in the weight, then the only other part of this that you need to worry about is Xing out the weight there, still completing your concentration times 1,000, and divide that by 60, which is your time factor. And that'll give you a factor number that is not weight-based. It'll just be a factor number for that particular medication. And then you're just doing desire over have again in order to make that work. All right, so we'll come back to that in a minute here. The next thing to show you as far as another method, and this is my quick and easy way that some of this may be a review, especially for the medics out there. I don't know if you learned this in medic school or not, but would be the clock method. And I like to utilize both methods when I'm out there. The clock method when I just need to do that really quick in my head calculation. However, I usually double check things with my factor method just to make sure that I'm coming up with the same answer in both particular situations. So with your clock method, first thing you want to do is to find the concentration in your desired unit. So if the bag comes in milligrams per milliliter, but you want it to be in micrograms per milliliter, you need to find out what that may be. So that's going to be your milligrams over your mLs times 1,000. And that'll give you your desired unit, so your concentration. So the next thing we need to do is to draw our clock. Sorry about that. And the concept of the clock is that the inside correlates with the time on the clock or your drips per minute or mLs per hour. So you want to go ahead and label your clock. Once you've found out the concentration of your particular medication, that's what's going to go on the outside of the clock. So for instance here, let's say that you have your Levophed. So your Levophed, you have 4 milligrams in 250, times that by 1,000. And I'm hoping that if you guys have your calculators out or you're doing this shorthand, that you're coming up with a number of 16, right? Okay. So with that being said, 16 is what goes to the top of your clock. What's half of 16? 8. Half of 8. And in between 8 and 16 would be 12. So the way this all works is that if you know that you want to run your Levophed at 4 mics a minute, you look at where 4 is on the outside of your clock, and that 4 correlates with your drops per minute or your mLs per hour. So if you do the long math through the other method, you should come up with 15 as the drip rate. And I'll talk again about that in a little bit more. You can also do this with those weight-based medications. And we'll reinforce this again a little bit more, but with those medications such as your dopamine, where you're looking to do mics per kilo per minute, you're still going to have the same interior to that clock, but you want to multiply your kilograms by an easy number. So say you want to start that dopamine at 10 mics per kilo per minute, you would take 10 times your patient's kilograms, and wherever that would correlate to on the clock based off of your concentrations, is that would be what your drip rate is going to be. So let's go through some of those, and I'll show you both methods and see that we hopefully come up with the same thing. All right, so let's talk about your dopamine first, since we were just discussing that. So your standard concentration of your dopamine is going to be 400 milligrams per 250 mLs. So the first thing you want to do is find the concentration that's within that bag there, based off of what you're going to be running this at. So you're going to run this at micrograms per kilogram per minute. So let's start off here with 400 per 250, and we're going to do the factor method to start with. So 400 per 250, we're going to multiply that by 1,000, divide that by 60, and divide that by, let's say it's me that's receiving this medication, so a 100 kilogram patient. I'm hoping, since you guys all have your calculators and you're working along with me here, that you're getting a factor number of 0.27. At that point, it's simple to do your desire over halve. And your desire over halve should be, say we're going to start this infusion at 5 mics per kilo per minute, 5 over your factor number, and that should give you 18.5 mLs. So you need to increase this to 10 mics per kilo per minute. Desire over halve again, 10 over your factor number, since that's a constant for that patient and that medication. And that should give you 37 mLs per hour. All right, just to prove how all of that works with regards to the clock, we're going to label our clock again. Okay. And we said we need to figure out the concentration in the bag. So if you take 400 divided by 250 times that by 1,000, I'm hoping that you come up with 1,600. Half of 1,600 is 800. Half of 800 there is 400. And we're looking at 1,200 between the 16 and the 8. So this is where that one extra piece comes in when you're talking about the clock method. So for your dopamine clock, and we want to run this at, we'll make it easy, choose 10 as our number for 10 mics per kilo per minute. I'm going to take 10 times my weight of 100 kilograms, and that should give you, hopefully, 1,000. Right around there is where you're going to say 1,000 is, and hopefully 1,000 correlates with 37 mLs on your clock. I'm hoping that makes sense so far. Let's do another one. All right, let's do Levophed this time. We said our standard concentration of Levophed is going to be 4 milligrams per 250. Oftentimes when you get to referring facilities, they have standard concentrations of 8 milligrams per 250. So we can take a look at both of those. Okay, so first and foremost, if we look at our standard concentration, we're going to do 4 divided by 250 times 1,000, okay, and divide that by 60. We don't need to worry about a weight factor at this point because we're not doing mics per kilo. It's just going to be mics per minute is our infusion rate. So when I do the math for this, I get a factor number of 0.267. When I look at the 8 milligrams per 250, for that, I get a factor number of 0.53. Okay. So let's say that we want to start this medication infusion at 4 mics a minute. So again, desire over have. 4 over your 0.267. And when I do that calculation, I get 15 mLs per hour. Same thing over here. If we want to start the higher concentration at 4 mics a minute, 4 over 0.53, and then I get 7.5 mLs an hour. So let's take a look at this on the clock. So we need to figure out what our concentration is to go on the outside of the clock. When we did this initial part of the calculation up here, the 4 divided by 250 times 1,000, we should hopefully be getting 16. So again, 16 is what's going to go at the top, 8 at the bottom, 4 on the side, and 12 over here. So if you want to run this infusion of Levophed at this particular concentration for your 4 and 250, and you want to run it at 4 mics a minute, your 4 mics a minute will be right here at 15 mLs. With the higher concentration on your Levophed, take your 8 divided by your 250, times that by 1,000, you should come up with a number of 32. Put 32 at the top of your clock, 16 at the bottom, 8 over here on the side, and we're going to do 24 in between the 32 and the 16. And we said that we want to run this at 4 mics a minute. 4 is halfway between 0 and 8. And 7.5 mLs correlates right in between your 0 and 15. So again, just a quick check with all those medications. I haven't really found any medications so far that it doesn't work with. So I hope that that method is helpful for you as far as doing your math within your head, as well as following through and following up on the medication afterwards. With regards to our medications, anytime you have any kind of infusion, make sure that you're documenting not just the dosage, but the infusion rate itself and the concentration so that we can all verify that your medication infusions are appropriate. And that should be in EMS charts for you. If you have any other questions, by all means, don't hesitate to get in touch with me. Be happy to answer any questions regarding the presentation or anything else with regards to your orientation. I hope things go well for you guys. And best of luck. Welcome to MedEvac.